Good afternoon, ladies and gentlemen. We now come to the annual slot for the BJUI lecture, and it's my great pleasure this year to introduce to you Dr. Robert Wachter, who is Professor and Chairman of the Department of Medicine at the University of California, San Francisco. Dr. Wachter has a busy still clinical practice, but is also responsible, he tells me, for managing over 1,000 physicians, managing a budget of over $500 million a year. So he's a busy man who is consistently voted in the top physician executives in the United States. He was responsible some 20 and odd years ago for introducing the term hospitalist and really creating the role of the hospitalist in American departments. And since then, he's gone on to have a very distinguished career. He's been president of the Society of Hospital Medicine and chairman of the American Board of Internal Medicine. More latterly, he's turned his attention to patient safety, where he has an international reputation, having published widely and won many national and international awards. He has also a great interest and has published, some of you may have read his books, on IT and the digitalization of healthcare, and he's advised our government, he's advised Jeremy Hunt in a recent review on the implementation of this technology to our NHS. So it's a very great pleasure that he's taken the time to come from San Francisco to talk to us this afternoon. And thank you very much, Bob, for making the effort.
Thank you. Thank you. It's a great pleasure to be here in this lovely city and your wonderful country. As Christian said, I've had a chance to spend a fair amount of time here, including for the review I did a year or so ago, as well as 6 months on sabbatical in 2011, and I enjoyed very much. And what I want to do, my talk today is going to be in 3 sections. The first is going to be the grumpy section, where I talk about how difficult digitization in healthcare has been, some of the challenges that we've seen that have been, I think, somewhat surprising. The second is going to be why I'm somewhat hopeful about the future. I do think we're seeing some trends that are changing, and there is some promise for real improvements. I was at the innovation session a couple of hours ago where we saw some of the manifestations of that. And the third session, I'll talk a little bit about the review that I did with some colleagues for the Secretary of State for Health and for the NHS in terms of what I came to learn about the state of digitization in the NHS, where there were opportunities, some of the recommendations we made, and where that is going. I'll go fairly quickly, in part to make sure we have some time for discussion at the end. So let me tell you a little bit about my own personal history. This is why I decided to explore health information technology. I'm not an informaticist by training. I'm, as was said, I'm an academic physician who's been interested in quality and safety and the organization of care for a long time. The first reason was my iPhone, and I think all of us have just seen technologies and been wowed by them, and feels like still feels like a little bit of magic, as I just got my ticket from United Airlines on my phone, and found and can find the best restaurant and all those sort of things. We're all used to a level of technology that seems to make our lives easier, maybe a little bit better, more convenient, and isn't all that hard. So my experience with my iPhone and living in San Francisco, where I live surrounded by some of the great digital companies in the world, convinced me that if healthcare could go digital, things would be better, safer, cheaper, and it wouldn't be all that hard. That, of course, was wrong. The second thing that I came to, the second reason I was primed to think a lot about technology was that for the past 15 to 20 years, I've been working in the field of patient safety. And I can't tell you the number of cases of medical errors I've seen over the years where the culprit was the doctor's handwriting. And so this is a fairly common error. Anybody recognize what this is a prescription for? So I think you have Coumarin, you call it here, or warfarin. This is we call it Coumadin, and that appears to be what it's a prescription for. But if you squint and have a vivid imagination, you will realize that the physician intended to write a prescription for a drug called Avandia, completely different drug, completely different side effect profile, completely different dose, and the patient was harmed by that. So those of us that saw errors from doctors' handwriting or not realizing a patient was allergic to a medicine, or the information in the office didn't make it to the hospital, or the information on the ward didn't make it to the operating room, couldn't help but expect the computers would enter our world, make things better, safer, more productive. That's what I was thinking until about 4 years ago, when at my institution, which is generally ranked in one of the top 10 hospitals in the United States, a terrific place, we had a kid who was supposed to get one of these pills. This is Septra or Bactrim or cotrimoxazole, a common antibiotic, one of these pills twice a day, and in a completely electronic system with computerized order entry, barcoding, electronic medical record. We ended up giving this kid instead 39 of these pills. So the correct dose was 1. A nurse gave him 39 pills in a completely electronic system. And as I heard about how this error had occurred, I realized that although our computers had made healthcare safer in certain ways, and I think overall have made healthcare safer, this particular error could not have happened when we were using paper. And it's too long a story to get into in great detail, but it began with the doctor not realizing that the computer was set for milligrams per kilogram. Thought it was just milligrams, put in the dose in milligrams. So therefore a 39-fold overdose. The kid weighed 39 kilograms. But that wasn't really the story of the error. The story of the error was that alerts fired for both the doctor and the pharmacist saying you're about to make an error, and both the doctor and the pharmacist ignored the alerts, clicked out of the alerts. Why? Because they get hundreds of alerts a day, the vast, vast majority of them being false positives, so they've learned to completely ignore them. Then in the old days, if the doctor had confirmed a prescription for 39 pills, it's an absurd dose, it would have been, a label would have printed out of a label printer, a pharmacy technician would have picked it up and might have halfway through pouring out the pills out of the big bottle, would have said, "What the hell?" and turned to the pharmacist, another human being, and said, "Are you sure? 39 pills?" And they would have caught their error, but of course, that pharmacy technician no longer works there. It's been replaced by a pharmacy computer and a robot. The robot gets an order for 39 pills and with absolute precision pulls 39 out of the bottles, puts them in little shrink wrap packages, barcodes them, puts them in little rings, sends them in a bin to the hospital, where the final step was a young nurse saw an order for 39 pills, an absolutely nonsensical dose. Looked at it, said, "This is kind of weird," but she was young, she was in her first year, she happened to be on an unfamiliar floor that day, and she said, "Well, I better check it with my technology." She barcodes pill number 1, and the barcode says, "I need to see 38 more." Because the job of the barcode, the safety function of the barcode at that moment, is to be sure that the nurse gives the correct dose. If the dose is incorrect in the computer, it confirms to the nurse that that's the right dose. She barcodes 39 pills, tears these packages open, gives them to this 16-year-old kid who dutifully takes 39 pills, and just by dumb luck did not die, had a grand mal seizure, spent a week in the ICU, and I suspect will never have a urinary tract infection for the rest of his life. I heard that story and I just couldn't believe it, and it struck me that these computers and digital systems were doing lots of wonderful things, but had lots of unanticipated consequences that at least I didn't anticipate. And I heard doctors moaning about their computers and battling with their computers. It seemed to me that it was a more complex story than any of us had anticipated. So I spent a year thinking hard about it and interviewing about 100 people, spending some time here, to try to understand why computerization, in healthcare at least, was harder than we thought it was going to be and harder than it looked. So I want to give you a tiny bit of context about the American system. I think you're feeling some of these pressures in a slightly different way here. This is medical students at my institution at UCSF. They're wonderful, they're smart, they're optimistic. I was talking to them several years ago, and they seemed a little too happy, and I deal with a lot of unhappy doctors often, so I wanted to let them know how different the world of healthcare was that they were entering than the one I entered when I finished medical school 30 or so years ago. So I said, you folks should realize that you're entering a profession where you will be under relentless pressure to figure out how to deliver the highest quality, safest, most satisfying care at the lowest possible cost. It's going to dominate your career. And one of the students raised his hand and he said to me, "What exactly were you trying to do?" And I said, wow, that's a fantastic question. So in the old days in healthcare, we were not under tremendous pressure to deliver high quality, safe, satisfying care at the lowest possible cost. The best hospital in the US and the worst hospital got paid the same, best doctor, worst doctor. Our outcomes weren't being measured, quality wasn't being measured, safety really wasn't a thing. There was a lot of money sloshing through the system, so productivity wasn't all that important. That has utterly changed in the United States just in the last 10 years or so. Obamacare had a little bit to do with it. The forces that led to that were actually happening well before Obamacare. So all of us in leadership positions are feeling tremendous pressure to deliver better, safer, less expensive, more satisfying, more equitable care. We're being measured on it. It's being publicly reported. And now increasingly the payment system hinges on how well you do. That's the first mega trend. The second is this. The second is in the space of the last decade, the American healthcare system has gone from a paper-based system to a digital system. Pretty short amount of time. The take-home message from this curve, this is electronic health record adoption in American hospitals. The take-home message is a decade ago, fewer than 1 in 10 American hospitals had an electronic health record. Now, fewer than 1 in 10 does not. And if you look at private doctors' offices, the curve is pretty much the same. So we've gone from the most information-intensive business known to man, I believe, whose information artifact, the way you collected, stored, and moved information around, was the piece of paper, the Post-it note, the fax machine, to an organization, to an industry whose information architecture is now completely electronic. That is an enormous change. How did that happen in the US? It happened because our federal government, starting in 2010, began doling out $30 billion in incentive payments to doctors and hospitals if they bought and implemented an electronic health record that met certain federal specifications. A fair amount of money, although if you think about it, $30 billion was successful in almost fully digitizing a $3.5 trillion system, which is our American healthcare system. So a pretty efficient investment, and it has led to what the feds intended, which is essentially the complete digitization of American medicine. I'll talk a little bit about some of the lessons from that experience toward the end when I get back to my observations from my review of the NHS. So to me, what I've just shown you reflects the two transformational trends in healthcare. Certainly this is the way it feels in American healthcare. The first is this value pressure. The pressure that we're all under to deliver care that's better, safer, more satisfying, less expensive. The second is the digitization of the healthcare system, the fact that we've gone in a decade from a system that was largely paper-based to a system that is now almost entirely digital. If you ask me today, what is the bigger one of these two trends? What's the one I obsess about when I'm driving to work in the morning? It's this one. There's no question that the big deal for those of us who have leadership roles in American healthcare, or even for a physician in his or her 3-person office, the bigger deal is increasing pressure, measurement, public reporting, payment changes that drive you to deliver care that's better, safer, and less expensive. I will say without very much fear of being wrong, and I would take good odds on this if anybody wanted to bet, that the digitization of healthcare will turn out 8 to 10 years from now to be the bigger change, responsible for more transformation, more disruption. I don't believe it is today. I go to sessions like the innovation session we just heard, and you see all these incredible things that are coming down the pike and are going to change things, but they're not quite there yet. Your practice today doesn't differ that much from your practice 10 or 20 years ago, and nor do the healthcare systems that we work in. But the reason I say that, and I have a sort of up-close view of the future because I live in Silicon Valley, is that I cannot think of an industry 15 years after ubiquitous digitization that had not been utterly turned upside down. And whether that's the taxi cab industry or the book buying industry or the journalism industry or retail or travel, it's every industry you look at. It doesn't happen right away, but 15 years after widespread digitization, it's never happened before that the industry was not completely turned upside down, including in most industries, the leading players at the beginning no longer being the leading players at the end, and in many cases being out of business at the end. Will that happen to healthcare? Will that happen to certain medical specialties? I don't think so. I don't think it will be that disrupted. There's certain reasons that healthcare is somewhat different, but I do think we're going to see the kinds of transformation that we've not yet seen in healthcare. I think this is going to be the most important force for transformation that we have seen. And if you say, well, we're digital and it hasn't happened yet, I'll tell you why that's happened. I think we're at the very earliest stages of digitization. So part of the reason I decided to take a year of my life and write a book about this was, as I said, I was excited about it. I thought it'd be pretty easy and straightforward. And I asked myself, what could go wrong as we went from paper to digital? It should be pretty straightforward. Let me tell you about a few of the observations I made in the course of a year of research. This is the first. This is a drawing that a 7-year-old girl did after visiting her pediatrician. The girl's a marvelous artist, and I was told by her family that this is something she liked to do after a new experience. She went to see her pediatrician, and she drew a crayon drawing of her recollection of the visit to the doctor. And there you see she is on the table. Next to her is her mother and her sister in the corner. And there in the other corner, with his back to the patient, typing away, is the physician. This has become kind of an iconic picture of American medicine today. There's one thing the girl got wrong, and that is the smile on the doctor's face, because the doctors are profoundly unhappy about the amount of time and energy they're now spending as very expensive and not particularly good data entry clerks, because the computer has required and enabled a whole bunch of additional data entry that maybe it was sort of asked for before, but when you were writing on pieces of paper, nobody could make you do anything. But now the computer is this enabler to say, well, let's just ask the doctor to document this one more quality measure, or these few additional things to get paid at a higher level, or this additional thing to make sure that he or she doesn't get sued. The sum total has been an enormous amount of documentation by physicians, such that the most popular new field in medicine in the United States are things people called scribes. So many practices, including our outpatient practices, now have young people who come into the office. There would be one other person in this picture, and they're the ones who type into the computer so the doctor can look the patient in the eye again. The first article about scribes that brought it to national attention in the US, I was partly responsible for, because my wife writes for the New York Times, and I came home one day and I said, honey, you got to write this story about the growth of scribes. I said, every other industry computerizes and immediately gets more efficient and starts laying people off. Only in healthcare could we figure out a way of computerizing and adding one extra person into the exam room. It's really amazing. So scribes have taken off. I don't think they're going to be a durable phenomenon, because there are a huge number of tech companies, the big ones you've all heard of, as well as a number of startups that are working on digital scribes, and I suspect within 3 to 5 years you will have a conversation with a patient that will end up in the chart. It's not just a transcript, it's not just voice recognition. The scribes are actually bringing some intelligence around what they put in and doing some editing and parsing, but the computers are going to figure that out and eventually, I think, replace scribes. So this is one I didn't anticipate. I don't know anybody who anticipated that the computers would make doctors as unhappy as they have, and they have in the United States. Burnout rates have increased, and doctors often attribute much of their burnout to their computers, and the fact that doctors are often not making eye contact with their patients, so busy are they filling out their computer screens. Here's a second one that I didn't anticipate, but I think I found quite interesting. When I was a resident, our equivalent of registrar, a trainee after finishing medical school, or actually in medical school, the hub of my hospital where I trained was not in the operating room and not in the C-suite where the executives lived. It was in the dimly lit chest X-ray reading room in the basement of the hospital, where this gentleman, his name was Dr. Wally Miller, basically held court every day. And every day you would go down to the chest room to see your films. And I see a few young people here. Those things behind him, those are called films. They're gone now. We haven't had them for 15 years, but that's what we had at the time. And one team after another would come through. All the medical teams, the surgical teams, the ICU teams would come through. And Wally Miller would be seated in front of the films. He'd put his foot on the button, the thing would spin around, the alternator, your films would come up, and you'd have a conversation about the patient, what was going on with the patient. He'd ask me, as a medical student, ask me what I thought was going on. I'd say, well, that looks like pneumonia. He would say, no, that's not right. Here's why this looks like tuberculosis. It was wonderful. It was interesting. As a student, it was a little terrifying. It was where the radiologists heard about what was happening on the wards with their patients. It was where the frontline clinicians like me learned from the radiologists by looking at the films and contextualizing the case. About 15 years ago in the US, and I suspect here too, the films left the building. PACS was invented, digital radiology. The cost of printing films, storing them became exorbitant. The cost of digital storage fell. And so within about a year, around the year 2000, the films went away. I've interviewed dozens of radiologists. I've read all the literature at the time to see if anybody even speculated about the possibility that the end of the films, the rise of digital radiology, would change those wonderful rounds. I can't find anybody who even gave it a moment's thought that it might change those rounds. And yet within a month, those rounds ended in most hospitals. And of course, the reason was you no longer had to go to radiology to see your films. You could see the images on any computer, first in the hospital, and then eventually you could see them at home. And so people no longer felt the need to go to radiology to look at their films, and the relationships that had been so wonderful between the frontline clinicians and the radiologists began to wither. I think the radiologists, at least in the US, for a month were pretty happy about this because they could now get their work done without all these pesky clinicians coming down to hound them. And then they started getting really, really lonely because they had lost the contact that they once had with their colleagues. One of the founders of digital radiology is this professor. His name is Paul Chang. He's a radiologist at the University of Chicago and an informatics expert. He's acknowledged as one of the founders of PACS, digital radiology. His father, it turns out, was a radiologist. You'd think if your son has gone into your field, made a profound impact by inventing digital radiology, his father would be very proud of his son. His father's nickname for his famous son is the man who ruined radiology. Because it really has become somewhat bloodless and separated from the front line of care in many institutions. And I think there are some lessons in this, and the reason there are lessons is radiology went digital 15 to 20 years before the rest of us. The first is the digitization of the thing, in this case the film, creates the opportunity to distribute it infinite times with perfect copies at no additional cost. If that sounds like a reasonable economic model, you're a little late because that's Facebook's economic model, that's Google's economic model. So you build it once, you build it really well, and you distribute it a bazillion times, and you figure out a way of charging people a couple of cents, often through advertising, when they look at it, and lo and behold, your company's worth $500 billion. So that's the lesson. The lesson for us in healthcare, though, is that social relationships and communication patterns that depended on us gathering around the film are going to be changed in a way that none of us anticipated, but I think in retrospect seem kind of obvious. Power relationships mediated by who controls the thing will be renegotiated. In the old days, if I wanted to see a film, I had to go into radiology world and talk to the radiologist. They basically held the key to looking at my films. They don't anymore. And so we're beginning to see hospitals and health systems experiment with new models. Do the radiologists really need to read every film? If the orthopedic surgeon reads a fracture, does the radiologist need to read it as well? In the US, they did because they got paid, but maybe the insurance company doesn't pay you for it anymore. Of course, the growth of teleradiology, now it's just as easy to read a film at a distance as it is locally, so we're seeing a lot of teleradiology, including some international teleradiology, taking advantage of both time zone differences and the fact that radiologists in many other countries make far less than US radiologists. But the most interesting thing, and the reason the radiology example is interesting, is that it happened a while ago. What we're seeing now is all of this, but applied to the entire medical record, applied to all of the data, and not just the data that you have in your doctor's office or you have in the hospital, increasingly medical records that will be created in part from data that the patient creates through filling out surveys or wearing things and sensors. So massive opportunity for change and disruption, the kinds of that we've seen in radiology. Here's where I knew things were really off the rails. This is an advertisement I found a few years ago for an emergency medicine physician job in the state of Arizona. It begins, Arizona General Hospital is coming to the state later this year. It's a suburb of Phoenix. Arizona General is a small boutique general hospital. It's a little tiny hospital. And then the ad began. Remember, they're looking for an emergency medicine doctor, so they have an emergency room, which is, you want that. Radiology suite with at least some of the latest toys. 2 state-of-the-art operating rooms, a little tiny place. 16 inpatient rooms, but the only part of the ad that was in bold, clearly they thought it was their main selling point, was they have no electronic medical record. They were advertising for a doctor saying that you can use paper and pencil here, we'll let you do that. So let me spend a few minutes telling you what I took away as the lessons from our relatively unhappy experience with digitization in the United States. And let me sort of preface this by saying, I've had people come up to me and said, well, you know, I saw you wrote a book about this and you've been talking about this. You're right, we should pull out the computers and bring back the paper. Those people are crazy. We can't do that, we shouldn't do that. And actually, I have no doubt that in my hospital, which is a 800-bed, big academic teaching hospital, that care is better and safer than it was before we had computers. There's no question in my mind, but also no question in my mind, it's been a much bumpier road than we expected, and we underestimated, by orders of magnitude, underestimated the complexity. Here's one of the first lessons, and the first lesson really is how extraordinarily early we are in this journey. Here are the 4 stages of health information technology as I see them. The first is the record is digital. It goes from paper to digital. The second is all of the parts get connected. The GP's office is connected to the hospital, is connected to social care system. Third-party apps, if you wear a Fitbit, if you have a glucometer, if you have a digital scale, that all gets connected. So if a third party builds useful decision support or some of the things we saw in the innovation session, those seamlessly connect to the enterprise core electronic health record. So there's one data flow through the entire system that's pretty seamless. The third is we glean meaningful insights from the data. We have all this data in the system, and we can now predict things that we couldn't predict before. Our ways of making predictions about outcomes of patients with certain PSAs or Gleason scores now are more sophisticated than they were because we have all this data going through the system. We're not doing clinical trials with 100 patients anymore. We can do clinical trials that look at 20 million patients. The fourth is that we take these insights and we build tools and apps and other things that we can use that actually improve healthcare quality, safety, patient experience, clinician experience, and decrease costs. When I look at this and I ask myself, where are we today? I've shown you already, at least in the United States, we have digitized the record. We're above 90% electronic health records in hospitals and in clinics. In the UK, you're essentially at 100% in the GP world and still nowhere near 90% in the world of the trust, which is partly what my committee was asked to address. We have not connected all the parts. The GP system often does not connect with the hospital system. 2 hospital systems with different vendors don't talk to each other very well. The third-party tools don't easily connect to the enterprise systems. We've done virtually no gleaning meaningful insights from the data, huge amounts of data sloshing through the systems, but how much resource have we put in, how many people have we put on this task of taking all that data and telling us things that we didn't know without having all that data. And finally, we've done almost no connecting these insights into tools, useful tools that actually work and demonstrably improve patient outcomes and do it at a lower cost. So to me, part of what feels disappointing is a recognition of we're really early in this journey. This is probably a 20-year journey by the time we get to the end, and we're in year 5 or so in terms of digitizing the record. I remember when I hired the person at our place who ultimately became our, what you would call a CCIO for our institution, I remember thinking, like, what will his job be after the electronic health record is implemented? What will he do? Well, we've implemented our electronic health record now 6 or 7 years ago, and he and the 20 other colleagues that he works with who are clinician informaticists have plenty to do because they're trying to do all the rest of it. So I think I was, and I think most of us were very naive that if you just get the electronic health record in, you're done. If you get the electronic health record in, you've started. And that's why getting it in effectively is important as a starting point, but that's all it is. Another insight that I had in thinking about this and writing about and reading the literature about digital transformation in other industries came from this gentleman whose name is Eric Brynjolfsson. He's a professor at MIT. And Brynjolfsson coined the term the productivity paradox of information technology. And he wasn't talking about healthcare, he coined it in 1993, so there really wasn't very much health IT. He was talking about the experience in other industries, financial services, retail, travel, other industries that had gone digital, There was the usual hype about how fantastic it was going to be. It's going to massively improve quality and productivity. And then digital came in and nothing happened. And everyone was left scratching their heads asking, why are we not seeing all the promised benefits? It was captured nicely by this Nobel Prize-winning economist in 1986 who said, you can see the computer age everywhere except in the productivity statistics. You go on the factory floor, you go to a Wall Street trading desk, there are computers everywhere, but we're not seeing the gains in productivity that were promised, and actually it was the promises that got us to go through the pain and the investment to do it in the first place. So that's the sad news, and it's been seen in every single industry. It's being seen in healthcare now, because although there is some evidence of gains in quality and safety, there's very little evidence of gains in productivity in the current state of computerization. The good news is that the productivity paradox in every other industry eventually resolved. Average time to resolution, 10 years. Healthcare, I'm guessing more like 15 to 20. Highly regulated. The mantra in Silicon Valley is fail fast. In healthcare, if failing means you kill someone, that's really bad. It's not like a bad restaurant app. And so there are a lot of reasons. Physicians are a pretty powerful lobby. Hospitals are a pretty powerful lobby. So there are a lot of reasons why true disruption will take longer in healthcare, but I believe it will come. And from Brynjolfsson and other folks who study this, the research says that the keys to unlocking the productivity paradox are two things. The first is the technology needs to get better, and clearly it does. If you use a modern electronic health record, they are decades behind in terms of usability, functionality, design from what we're used to in the rest of our lives. But it turns out that is not the most important thing. As Brynjolfsson and others have said, the most important thing is what they call reimagining the work. And that turns out to be a really profound concept. What he meant by that is that in industry after industry, we computerize, and all we do is replicate the work and the workflow that we used to use when we were on paper. And why? Because we're not creative enough to take advantage of the tools and rethink the work in a massive way. So we do what we're familiar with, we just now do it electronically, and it makes it a little bit better and a little slicker. In other industries, the lesson is, and this is why it takes some time, you need young people to come in and say, why are we doing it that way? And the answer is, well, because we always did it that way, and we computerized and just locked it in. And they say, well, here's a brand new way of thinking about doing this thing. Using digital tools as an enabler, but not simply digitizing the old way of doing it. You look at a patient's record in a computerized electronic health record. It looks exactly like a patient's record in a paper record. It's on what's now a digital piece of paper. It's got tabs, nursing notes and doctor's notes and all that. It's no more imaginative or creative than the clinical patient record on paper that was invented over 100 years ago. Why? Because we couldn't imagine something different. Then go to Facebook or go to Twitter or go to Wikipedia or go to YouTube and look at what a record could be if you reimagine what that would look like. And that's the sort of thing that I think Brynjolfsson's referring to. It takes time, it's challenging, it requires innovation, it requires flexibility, but that will turn out to be the key for resolving the productivity paradox. Here's why I'm now far less pessimistic than I was a couple of years ago. I think we're entering a new phase. The winners in the derby for building the electronic health record turned out to be companies built for that purpose. The companies that in the UK that built electronic health records in the GP space. In the US, there are companies like Cerner and Epic. These are companies that were built specifically to build an electronic health record. And that was not preordained. IBM tried, General Electric tried, Google tried, they all failed. So it turned out to get this right, you had to be a company that this is what you were about, because it was really hard, really complex, required a lot of domain-specific knowledge. These were the companies that were ready, in the US at least, when we went digital. But these are companies that have no special expertise in all the things we now need. What we needed in the beginning was a tool that would collect the data and kind of move it around. What we need now are tools that do data visualization, that do artificial intelligence, have wonderful user interfaces, help communicate with patients, with families, with other physicians, with others in the healthcare system. These companies have no special expertise in these things. They're trying to learn it, but that's not what they were built to do. We're also seeing a phase where some of their technical reasons where things are getting better. The architecture is beginning to open up. There are these things called APIs, which allow third-party tools to plug into existing systems that are relatively straightforward. And you're starting, I was on Google's advisory board for healthcare 10 years ago. And about a year into it, Google pulled the plug on our advisory board, and they said, this is too complicated. We're not going to stay in healthcare. They are back in now, but they know now how hard it is. They know that they have to partner with physicians, with healthcare systems in order to get it right. We saw examples in the innovation session of companies that really seem to understand the importance of partnerships. So I think all of that is quite hopeful. And we're starting to see evidence and examples of reimagining the work. So let me actually skip over this to just show you one example at my place. It's not a fancy example. I've seen all the latest gee whiz technology, but to me the issue is thinking about what we're trying to do and trying to come up with a new way of doing it that uses digital tools. So we have something called the glucose management service at our hospital now. And this is how it works. At 6 o'clock in the morning every day, we have an endocrinologist, a diabetes expert named Rob Rushikoff, who sees on his computer screen, a specially built screen out of our Epic system that we had to construct for him, sees on the screen the glucose trends, the insulin doses, oral hypoglycemics, prednisone doses, electrolytes, all the things that he needs to see on one screen to determine whether the patients are getting the right management of their glucose if they're in the hospital. Now, does he see every diabetic in the hospital? We have an 800-bed hospital. There probably are 200 diabetics every day. Far too much work. So that's not what he sees. What he sees are patients that have been screened by the computer as meeting one of these 4 criteria. So patients who have high-risk diabetes, the computer screens them, finds the 20 or so patients that meet those criteria, and sets up for him 20 screens where he can go one after another, look at how the patient is doing and what the doctors have, how the doctors are managing the sugar. That's him sitting in front of his screens. That's what the screen looks like. That's the glucose trend over time. I first learned of this about a year ago when one of our residents said, I opened up my medical record, electronic record, and I expected to see the cardiology consultation, which I called, and the infectious disease consultation, which I called. And there was this other consultation from the glucose management service, which I did not call. But there was a consult note from Dr. Rushikoff that came out of the blue. And she said that I have been Rushikoffed. So this has become a verb in our hospital. I got Rushikoff, meaning I went to the chart, there was a note from Dr. Rushikoff. And it turns out that through this intervention, published last year in the Annals of Internal Medicine, the proportion of hyperglycemic patients went down by about 40%. Hypoglycemic went down by nearly as much. I took Rob out to lunch one day and I said, how long does this take you to basically screen the entire hospital's diabetic population for high-risk patients and patients where we're not managing them correctly and you are giving input? So he looks at about 20 a day and he writes a note with recommendations for about 10 of them. And that takes him an hour. How long does it take him to do an endocrinology consult? If we called him to see the patient, that takes an hour too. So in the time that it used to take him to do one consult, he's improving the care of diabetes as well as education of all the docs taking care of the diabetic patients for the entire inpatient population. This doesn't require super fancy technology. It's not a startup with a $100 million valuation. It's just taking our existing electronic health record, reconfiguring a few things, but then asking the question, how can we scale the knowledge of a specialist so that it's generally available to generalists trying to take care of complicated patients? To me, it's a nice example of reimagining the work, and I hope it stimulates you to think about things like that in your own work. I'm going to spend the last few minutes talking a tiny bit about my experience chairing a commission that advised the NHS on its digital future, which was a great honor. So this is how this happened. This is the Secretary of State for Health at my hospital. Now, 3 years ago, taking a tour of the hospital. This is the screens that are in all the rooms in the children's hospital that show you when a new doctor comes in the room. It shows up on the screen who the doctor is. The kid can order from a menu on the screen. Some of the medical record is available there. He was impressed by that. He'd also read my book, which he has in his hand there. And he asked me to put together a commission to advise the NHS on its digital future. These are the members of the group. The main point is There were a fair number from the UK, but also a decent number from the US, one from Denmark. So really an international group. And I have to say I was extraordinarily impressed. Inconceivable in the US that we would invite someone from out of the country to chair an important commission. And to me, it's a great sign of strength and humility that the Secretary asked me and our group to participate. This is the report that came out now about close to 2 years ago, Making IT Work, Harnessing the Power of Health Information Technology to Improve Care in England, and available online if you want. So just a little bit about the context of the review. As you probably know, there was a major program in the UK to digitize the National Health Service called NPFIT. It was mostly a failure with a lot of money spent but relatively little to show for it, run way too centrally determined without any real engagement or buy-in from frontline providers. GP sector digitization, on the other hand, had gone well, largely because it was owned by the physicians. The 5-year forward view demanded another effort aimed at digitization and interoperability. There had been £4.2 billion allocated to try it again, and I think part of what Secretary Hunt was asking of us was recommendations about how best to spend that amount of money. And he and the NHS wanted to learn from past experience and learn from our experience as well. So here were the distillation of our experience that I shared with the Secretary and our committee, I think, embraced. The way we did it, which was basically a decentralized program of incentives. So NPFIT was a highly centralized system where the government determined what the northwest quadrant of England, which system they would buy, which consultant they would use without any engagement or buy-in or any choice. We didn't do that if a U.S. hospital or doctor's office could buy any system that met certain federal standards and would get money to do that. And that worked. If working was getting computers into doctors' offices and hospitals, the curves I've showed you already say that it worked. It was important to develop a strong path to interoperability. The systems still don't speak to each other very well, and we probably should have pushed even harder on that early. Current EHRs aren't very good, so try to avoid vendor lock, meaning one of the things that I worry about is that in our world, the system built by a company called Epic is now the system in virtually all large hospitals and very hard to displace them. Once they're in, you've spent so much money, it's hard to avoid what's known as vendor lock. EHRs can enable some good stuff, but it can also lead to lots of bad practices, copy and pasting notes, over-regulation of practices because it's easy for people to ask you to document one more thing, alert fatigue, and has led to some level of physician unhappiness. And electronic health record implementation is just a start. Need to create and enable an ecosystem where some of the third parties we heard about earlier are there building new tools specifically to help the urologist do something. No EHR, general EHR company will do that. So you need to create an ecosystem where other parties will enter and the barriers to entry are not too high. And a very important takeaway that we felt, and the committee felt, was in the US, a hospital like mine has about 20 individuals who are trained clinicians, physicians, nurses, and pharmacists, who also have advanced training in informatics. And those people have designated roles. They actually have a lot of prestige. They have pretty decent-sized budgets. And their job is to be the bridge between the clinicians and the IT people. And when we went to UK hospitals and we'd say, you know, do you have anybody like that? They'd say, yes, we have Joe. We have one person. He's got 2 sessions a week to do this. Woefully inadequate. And it turns out there wasn't a workforce of clinician informaticists to service those bridges. So briefly, the recommendations we had, at the time we started, the Secretary was talking about having a paperless system within a few years. We asked him to stop saying that because we thought it was both impossible and would require too much money being spent too quickly. We came up with the idea of digital exemplars to spend some of the early money on trusts that were already somewhat digital to help them get better and help them bring the next group up. We thought that was a more sensible way of trying to get it right. We thought giving local trusts the authority to build the best system for themselves was better than a fully centralized system. We thought the clinician informatics workforce needed help, including at the local level as well as at the national level. We thought there should be a national person who was in charge of overseeing digitization of the healthcare system. My committee at one point realized, we turned to each other, we said we've met with the 20 people in the NHS and the Department of Health who have the most to do with digitizing the system. And I turned to the committee and I said, have we met anyone yet of those people who's ever seen a patient? And the answer was no. And we said that can't work. And so we made a strong recommendation there needs to be a national CCIO, and that interoperability is crucial. And really all the recommendations we made were followed. This is Matthew Swindells, who leads the effort to take the funding and move it out, and the Digital Exemplar Program was what he was announcing here. Yes, the local trust had authority to buy the best system for them. The Digital Academy was just launched to train a new generation of clinician informatics experts. There was a national CCIO. Keith McNeil was the first, the former CEO at Addenbrooks. And interoperability, making progress, not quite there yet. But I was quite impressed by the degree to which they took our recommendations. Is this easy? The answer is no. It is really hard, really complex. Unanticipated consequences should be anticipated. One example is this. I don't know if this made it over across the pond, but in the US, this is IBM's Watson computer system taking on the champions of this game called Jeopardy, a trivia game contest, and whooping them. You see beating the two best champions in the world up to that point, threefold. Watson came out and said, well, we're going to do this in healthcare now, and here's Watson for Health, lots of advertisement, lots of buzz. They came to a number of famous American hospitals to work on things, and just about a month ago they announced that they're laying off maybe up to 70 or 80% of their workforce because things have gone so badly. So this is a really hard row. My own belief is that we have passed a tipping point and we're going to enter a phase now where we're going to start seeing real value, partly because Google, Amazon, Apple, all those companies are jumping in, partly because there's a lot of venture capital money coming in. There's a lot of, all of the companies that now have transformed other industries have recognized that there are massive opportunities in healthcare. And I believe that the combination of the pressure to deliver better, safer, less expensive care, you're obviously feeling the latter part even more than we are, new capabilities in AI, easier connectivity between different information technology systems, new healthcare business models and capabilities, and what I think we're going to see soon, which is ubiquitous digital data. There will be data coming from all sources, aggregated, will drive transformation. Won't be easy, won't be quick. It's going to take another 10 to 15 years. But I think at the end of it, we will see a healthcare system that's better and safer and less expensive. So I'll leave you with this story. This is the Choluteca River in Honduras. There's a part of Honduras that gets a lot of hurricanes, and about 25 years ago, they needed to build a new bridge over the Choluteca River. And because of all the hurricanes, they said, we better build a terrific bridge, one that can withstand terrible weather and hurricanes. So they contracted with the world's leading bridge design firm in Japan, as it happens, to build the Choluteca Bridge. And they did that, and the bridge was there. And as they feared, a year or two after the bridge went up, along came Hurricane Mitch, blew down hundreds and hundreds of houses, killed a lot of people, terrible hurricane. But the bridge, as they'd hoped, was left standing proudly with barely a nick. You can imagine the engineers in Japan giving each other high fives about what a great bridge they built. There was only one little problem, and that was that the river moved. This is healthcare, certainly in the US, and I think here as well. The river is value. The river is, we are being expected to build and be leaders in a system that delivers the highest quality, safest, most satisfying care at the lowest cost. It's inconceivable that the NHS, as it was created, can do that. It's inconceivable that any existing system can do that, given all the pressures of the aging population and other needs for the money. And so we need to build a new bridge. And the new bridge is going to have a lot of digital in it. It's not going to be all digital, but it's going to have to have a very strong digital infrastructure. And as part of that, it's not just the computer system, it's not the technology, it's creating a cadre of people, including all of you, who think hard about reimagining the work. How can we do this thing in a new and different way that is best for our patients, best for our system, and takes advantage of new digital capabilities? Thank you so much for the honor of talking to you today. I really appreciate it.
Bob, thank you very much for that very comprehensive, beautifully balanced view of this complex new field. We have got a few minutes left, and Dr. Wachter's kindly said he's very happy to take one or two questions if there are topics people would like to raise. Steve, on number 2 there.
Thanks very much for a very stimulating talk.
Thank you.
I mean, clearly you can make the electronic health record work. The issue is a lot about interoperability. And of course, in this country, we talk a lot about social care as well as health care. And one of the things that we really shied away from is having a digital identity that covers the whole piece. What are your thoughts about the necessity to actually carry the equivalent of an identity card so that you can make all that interoperability work?
I think it's extraordinarily important. I think it's a huge flaw in the American system. We're actually not allowed to create such a thing. Congress has forbidden it. When the issue came up about 20 years ago, there were protests that recalled the numbers on people's arms from Nazi Germany and said we shouldn't have anything like that. And what that means is matching patient records is extraordinarily difficult. People have similar names and you're trying to make sure this is the right Jane Smith. My understanding is you have an NHS patient identifier, which makes things a lot easier here, at least in the healthcare system. I don't think it connects you up to the social care system. So if you can get there, I think that's a massive advantage. And the risks of privacy are real, but they're going to be real any way you do it. I think the benefits for patients of having a single identifier would be tremendous, and I hope you can get there.
Microphone 1.
Yeah.
Hi, I'm actually an e-health researcher, so not a urologist, and also an implementation...
Move a little closer to the mic if you can.
Sorry, I'm an e-health researcher and an implementation scientist, so not a urologist. And I'm actually working with one of your digital exemplars. And one of the things we're looking to do is to integrate the use of behaviour change apps with the electronic patient record. I just wondered if you had any examples of, I know you said you're still getting there in the US, but do you have any examples of where you've been particularly successful in trying to do that?
In behavioral health specifically, mm-hmm. It's not the world I work in. I keep hearing about terrific apps that are quite helpful. I guess the one I heard of recently that I thought was fairly cool was a telemedicine system where there's a shortage of psychiatrists in the United States. And so the way this works is a lesser trained and less expensive person does the interview with the patient, and it's basically filmed, and the psychiatrist watches it in about half the time that it would normally have taken to do the interview, and then makes recommendations that way. And so the idea of telemedicine changing the geography of healthcare and allowing people to do things at a distance, but also changing the temporal nature of it, because often the time that you take to collect all the data probably can be shortened, and the time of the clinicians is one of the most valuable commodities we have. So yeah, we're starting to see those kinds of things, but I'm not familiar enough with the mental health world to know. Thanks.
Bill, is that Bill?
Bill Turner from Addenbrooke's in Cambridge.
Do you know everyone's name here? I've been hanging out with Christian for the last day, and it seems like he knows everyone in the audience. Very impressive.
So Dr. Wachter, you came to listen to a small group of us at Addenbrooke's as part of your review, and that was great. Just with our experience, we are coming up to 4 years from going live with Epic. I think you've absolutely nailed it with the presentation today. All absolutely spot on.
Thank you.
Clinical informaticists. That's a real challenge here, and I think it's something that people could become extremely interested in, but that has been a very difficult part in our experience, as you've set out for those reasons. One of the challenges is that our system, I think, was built for business purposes initially. So Epic, as I understand it, was for primarily getting the hospital administration side in order. And so one of the difficulties we have is the tension between running the system for the trust's benefit overall and overarching safety measures against the things that we see and think would be helpful in daily practice, and using the examples that you've said of what we do in IT in our daily lives. Why can't we have that level of sophistication?
Yeah.
So do you have experience from your place or that you've come across in the US for how to stimulate clinical informaticians into this process and how to help them deal with that tension?
Well, first of all, thank you. One of the first things my group did was go up to Addenbrooke's, because when I got here, I think in our first meeting, I kept hearing about what a disaster Addenbrooke's was. They had just put in Epic. The CEO had just been fired. They were missing their targets, all that. And I said, that's interesting. I'd love to see that. And we went up there, and I thought it was the most impressive implementation we'd seen in the country. And of course, the implementation was bumpy, because they always are, and it was ambitious. But it was working well. I thought the level of engagement among clinicians was better than anything I saw in other places. We visited many other good places, including Salford and others. So I was very impressed, and it was sort of an interesting irony that the fired CEO became the first national CCIO, and is quite good. The workforce, I think, is easy if you create good jobs. So in the US, telling a technologically sophisticated medical student that there is a job where you can be a doctor 70% of your time and work in IT and do innovation 30% of your time, and it's a good job, and you get paid reasonably well, and you have a decent amount of prestige, and we're doing some cool stuff here. I mean, a lot of people want that job. So the problem is not a supply problem. The problem is creating those jobs and the training pathway to professionalize that position. Once you do it, people will want to do that job. For young people, this is a very exciting place to be. The electronic health records, people often say that it was built to please the chief financial officer. I think that's a little bit simplistic. I think it was built to serve a multitude of functions, and the one that was a must-have was the billing function in the United States. So because the CFO had to sign the check for tens of millions of dollars, it had to at least do that very well. And so it tries to do everything. It tries to be a financial system, a measurement system, a clinical system, to some extent a communication system. And because of that, it doesn't do any of those as well as it could if it was a single function. The problem is it does, at least in the US, it does need to do all those things. It has to create a bill. It has to help a clinician take care of a patient. And so I think it's an open question whether the future will be in Epic and companies like that getting iteratively better as they get more clinician input and more pressure, or it becomes a more atomized system where you have Epic as your core system, but then you have a number of third-party systems that you've bought that serve certain additional functions. The problem with that is they have to weave together seamlessly. If the doctor has to go and use another system to accomplish something, it's not going to work. It has to be one-stop shopping, single sign-on. And I think that's beginning to happen. The problem is if a system better than Epic came out tomorrow for your hospital and my hospital, it would have to be 10 times better and 10 times cheaper to replace Epic, because once it's in, it's really tough. So I think we're going to see a more pluralistic future where Epic or Cerner or whatever you bought will be your core system, and we are going to see a sort of richer environment of third-party applications, and the technology is getting much better in terms of weaving them together into the core system. So I think that's where it's going to go.
Thanks.
Just one final question then from David.
Fascinating talk. Thank you very much.
Thank you.
In Australia, we have probably a model which is similar to the American model. We've got a combination of private and public institutions delivering healthcare, and certainly most medical practices, including general practice and specialist practices, are computerised. But there's a marked reluctance to integrate, and one of those concerns relates to data security and patient confidentiality. So how do you deal with the data security from a practical perspective, and how do you deal with it from a perception perspective?
Yeah, I think data security may be our hardest problem now, and it certainly has emerged very quickly, and we're starting to see all the breaches. You've seen some here as well. It's not obvious to me that less data sharing is the answer to data security. I mean, even within a large healthcare system, my one system has records on 4 million patients in offices all over the Bay Area. So the idea that we figure out a way of connecting to other hospitals or other clinics that markedly increases our risk for data security, I don't think the scale is the issue. I think the core issues of how do you keep data secure in a digital environment are the big issues. What we're all doing in the States, you're probably doing the same, is recognizing that none of us, even a big place like ours, can have and retain the competencies to do this well. So we're all moving it's sort of paradoxically, you'd think it'd be safer if you kept it in your place, but probably it's going to be safer if it's an Amazon or Google's cloud, and there are tools that they're building to figure out ways of trying to keep it secure, and that's what we're all doing. And once it's up there, then once you get past the patient matching problem, you at least have the possibility of moving data across healthcare systems. Nobody's come up with the answer to data security. I don't understand blockchain very well. Some people think it's the answer. But we're always told, well, healthcare is behind in data security, but you see huge breaches in financial services companies that have spent billions of dollars on this. So it's a really hard problem. We'll never completely lick it. But the advantages of interoperability and data portability, and not just in terms of an individual patient experience, but the ability to do research on large cohorts of patients that you could never collect in a single trust, are so great. And I think the incremental risk of data security by having better interoperability is just not that high, that I think the advantages outweigh the risks. And we're just going to have to figure this out. I don't think any individual trust can figure this out. I really think it's going to be, the solutions are going to be at a higher level and probably built by some of these companies that are used to doing data security on massive amounts of data from other industries.
Well, thank you once again, Bob, for a very stimulating discussion and presentation.
Thank you so much.
Very great. Thank you.
Thanks.